Good morning, guys. Don here. Welcome to Podiatry Practice Mastery, the $1 Million Minute. I'm going to go over the things that hopefully is going to help my practice get to the $1 million mark and beyond this year. This is a recording of a day, it's a Monday. There were 21 patients. There were 40 minutes of openings, and so there's like 2 open slots here. So let's get into it. The first patient was a 59-year-old female. Sarah, that I saw, she was here for an ingrown follow-up. She's been doing well with it. She had a kind of a challenging case. Initially, it was an ingrown, and then she had an onycholytic nail that I trimmed off. Actually, I think I almost had to ovulse the whole nail. And then as the nail started to grow back, it had been onycholytic in the past. So what I did is I applied Onifix. So I put 2 Onifixes on, usually 3 to 4 months apart. And those were about ready to come off. She's actually an attorney. She was really pleased with this Onifix. I find sometimes with onycholytic nails, Onifix works well to help it to reattach. She wasn't using it as much for the ingrown portion, but more for the detached toenail. Next patient was a 49-year-old, ingrown follow-up. I talk a lot about the MVP. This might be the LVP, the least valuable patient. So these nail, ingrown toenail follow-ups, I'm trying to avoid, but this is someone that I did see. The reason I saw him is he is an actual rep for Athena. So I tried to negotiate. It's funny because Athena is from Massachusetts, who we're using or we're going to be transitioning away from. And he tried to get us a better rate. And unfortunately, the rate just wasn't good enough compared to ModMed. So we are still transitioning here. Our transition month is April. So we're going to start transitioning things over. I think they can only onboard so many people at a time. So even though we made this decision a few months ago, the onboarding process will be happening in April. Next patient was a 38-year-old female, and she was here. She had a kind of a yellow discoloration on all of her toenails, and it happened only in the last month, and it didn't really seem like fungal, and I think it was either from a toenail polish that she had or toenail polish remover she used, or she was using spray tan, so potentially that spray tan could have gotten on her toes and kind of caused the staining. So I have these little nail buffers and files. I don't normally use nail files or buffers, okay, not something I like to do, but I have them when I do Carry Flex, and so I just have them sitting around. So I tried to buff out that yellow, and all of it came off on one toenail, so I'm like, here, you can take these, do it yourself, or go to a salon and have them buffed out. So it was a real kind of a simple thing. So for all 3 of those, there was no follow-up. Next patient was a 55-year-old female. She came in for an orthotic follow-up, and she, because of the paper that we gave her inside the orthotics when we dispense them, that offers people a second pair of orthotics, she opted to get a second pair of orthotics. So our orthotics, second pair, we give them $250 off the second pair, and that's where a lot of patients, they prefer a second pair. She also had a fibroma on the plantar arch region, which I didn't notice last time, and I did an ultrasound of that, showed it to her, and I'm going to see her back as needed since that fibroma does not bother her. But I did do an ultrasound and an office visit that time. Next was a 78-year-old patient. He was here for a nail sample, and it actually came back negative. And so this is where I'm trying to get away from doing either nail samples or seeing people for nail samples back. So it was negative. He didn't really want treatment, and so it was kind of a LVP, least valuable patient type of a visit. So once again, our focus here is trying to get to the $1 million mark, so trying to have a profitable practice. That's why I'm trying to distinguish these things for you guys. Next patient, she was a 55-year-old female. These are one of these intense ones. I don't know if you have any of these, but we have this messaging system through text message, and I think she has like a string of like 50 messages, and she sends portal messages to me, and just kind of a very, I don't know if it's needy patient. I think we all have them, but she did have she had a previous matrix. She had some pain in the nail edge, so I did a revision matrix at her nail edge, and I'm going to see her back. Not seeing her back. She'll see me back. I'm sure I'll get a contact or multiple pictures or a message from her. I think we all have these types of patients. Next patient was a 74-year-old patient that he had nails, and he started initial nail care because of the 3 thickened nails. and he'll be coming in to see one of the other doctors at that office. So in all of our offices, we have 4 doctors. Each doctor does a half day per week of nail care, and I think I mentioned that before. So I was in my Monday office, which is Westboro, so I don't do it there. I only do it in my Worcester office, and so one of the other doctors will pick that up. Next patient, this is a patient. She had a cortisone injection to the anterior ankle, and once again, as I'm trying to do now, I was explaining, the pain went away, but to prevent recurrence and help kind of stabilize your foot, we're going to do an orthotic for you to help with the mechanics of your foot. And so she did an orthotic, so that was orthotic number 2 for the day. Next patient was an 81-year-old. Once again, this is a new patient. She had just needed nail care, so she'll come back in our nail care day. So new patients, we don't make them come in just on our nail care day, right? They can be seen any day, but then when they follow up, they're going to follow up with our nail technician. Next patient, once again, was a nail sample follow-up. Now this patient, it looked like a fungus. It came back negative. I find sometimes that these can be false negatives, and so in her case, I gave her an option. We can either just do that, and if we don't see any improvement, or there's no harm done really. And so, but for her, because of the type of nail, it's one of these like kind of thickened nails that doesn't look yellowish. I think it's more, I'm going to give her diflucan. I think that tends to work a little bit better, in my opinion, for that type of a nail. Next patient was a Shockwave. This is EPAT number 4. She's doing better. And then the last patient of the morning was second MPJ pain. So this is kind of a challenging one. This gentleman, he has some right second MPJ pain, some spurring on the top of the joint, no fracture noted on x-ray. I did an ultrasound, showed an effusion in the joint. And this is the dilemma. He's having left knee surgery coming up, and he's going on vacation. Now, I do very, very few second MPJ joint injections. But in this case, trying to get ready for surgery because he needs to ambulate on the other side, going on vacation. So I did do a little bit of cortisone, 1.5 cc's of cortisone in that second MPJ. And I did talk to him. I gave him the riot act saying that this could blow out your plantar plate. There could be a need for surgery here, this and that. He is fully aware. And I am actually going to have him circled on my paper to give him a call, see how he's doing. So I do not do a lot of these. I think they cause a lot of plantar plate tears. I've done it. I've had them come in. So I'm just kind of letting you know, rationalizing my irrationality for this patient. That was the morning. So the afternoon, first patient was a 55-year-old female. She is actually the mother of a nail technician that trained with me. So I had another nail technician that trained with me for a number of weeks. She had a salon. She's going back to be a nurse practitioner, so she's going to go for the real money to do aesthetics. She's a real go-getter. I'm going to do her mom's bunion surgery. And as I was doing my bunion pre-surgical discussion, I don't know if you've seen that. If you go to patientpresentations.com, you can see mine. And in there, I've added a slide that talks about kind of improving surgical outcomes and doing pre-surgical Shockwave. And when I said that to her, and I say this to everyone now because I just added the slide, so it just adds what I say. She's like, yeah, I want that, because she has kind of a history of fibromyalgia, and she wants to increase the ability to heal. So she's going to be having a bunion and a hammer toe repair, and I'm going to be doing 3 sessions of Shockwave prior for her. So that's to prepare the tissue to help skin healing and help the healing afterwards. When I was at most of the Shockwave conferences, they talk about this. They give kind of the tummy tuck type of picture they show, and they show half the tummy tuck was done with Shockwave before, half of it was done with it after, or without having it, and there's just a big scar difference. And so for her, I'm going to be doing these 3 sessions of Shockwave pre-operatively. I also had a good experience on a patient that I was treating for Haglund's that ultimately the Shockwave, or she just couldn't tolerate the Shockwave, or it didn't work, and we had to turn it into a spur removal and reattachment, and she just responded so well on that other side that I did Shockwave before. So I was thinking of more when I talk about Shockwave from like the Achilles or the plantar fascia or things like that, but I think it could also work for the bunion, so I'm gonna try it out. I'll let you guys know how that works. Next patient was a 75-year-old. This is a patient he had elevated. I had two patients like this. One was a 75-year-old guy, really elevated LFT, so I didn't feel comfortable putting him on Lamisil. I wanted him to check with his PCP. And then this other patient, he had elevated LFT as well. And so for these guys, I don't feel comfortable putting them on Lamisil. I don't know if anyone else does, but the LFTs were like double what they normally are, and he's got fatty liver. Does anyone else do Lamisil on these patients? If you do, shoot me an email down at podiatrypracticemastery.com. I'd love to know what you do. I sometimes, if it's kind of borderline and it's always been elevated, then I'll monitor it with monthly LFTs. But these ones I just didn't feel comfortable doing it. Next patient was a status post amnio. I did an amnio last time on his Achilles at the insertion region, and he had a little bit more pain somewhere else in his foot, but not in the Achilles. I think his actual Achilles pain went down. He was booted for about 5 days, felt better, and then when he got out of the boot, he had a little bit more pain, which is common, so he did Shockwave number 3. So this would be an MVP of mine, that he's doing 6 sessions of EPAD, and he had an amnio. That was last week, the amnio was. I'm also having an issue with amnio. I mentioned this to a few people. They used to charge $500, now they're going up to $1,200. And so at $500, I used to charge $1,500. Now at $1,200, when you try to triple it or double it, it's just going to be kind of expensive. So I don't know if anyone else has an amnio vendor that you really like. If you would, just please send me an email or just reach out to me and let me know who you use. And if it's a lot less, I'd love to know. And if it really works, it's a good product, let me know as well. Okay, next patient was a new patient, 76-year-old female with a fissure, and she came in. She couldn't get it better. I'll tell you my little treatment plan that I give these ones. So in the morning, they put on 40% urea, and then use a heel cup in their shoe to prevent friction. And then at night, I have them use the sleep and heal. As well, sometimes I use super glue to kind of glue them together. Actually, I have a funny story. I had another patient with a fissure. I think it was yesterday as well. And I put this super glue on it, and then I was treating something else, and they put their darn foot on my little plastic thing in my chair. Thankfully, I have these plastic covers, and like stuck to it, and it didn't stick to it, but it like got this big gob on it. And then I'm trying to use like Goo Gone with the patient, and it's like smelling fruity in the treatment room, and it was just a fiasco. So I think I put a little bit too much Gorilla Glue on the heel. The heel didn't crack open anymore, but I got glue all over the place in my treatment chair. So it's kind of a bad move on my case. Next patient was a nail sample follow-up that was negative, and a anonychia follow-up. They were fine. And then I had a little boy, 12-year-old. I don't see this that often, but he was a 12-year-old with apophysitis at the 5th metatarsal base. So 12-year-old kind of hockey kid, hurts kind of pushing out, and so I helped treat that with kind of better shoes, foam rolling on the peroneals proximally in the muscle, and then kind of stabilizing things. And we talked about possibly Shockwave if it doesn't get better in about 3 weeks. And then second to last patient was an 8-year-old for Cantharidin number 2 with mom. And then the last patient was a second med head pain. These are kind of challenging. Second med head, capsulitis, metatarsalgia. She is on Shockwave number 5, and she is doing very well. Slow progress, but she can tolerate a lot more Shockwave than she ever could in the past, especially the focused. Initially, when I was starting the focus on her, it was like 0.01 or 0.03, and now I'm all the way up to kind of like 0.15, which is a big difference in terms of how much she can tolerate it. She's getting better. I know she doesn't quite feel it all the way, but this is slow progress for something like that. Anyway, that is my day. I want to let you guys know I am doing a talk. It's later this morning for a group of primary cares. There's a group here called Charles River, and so one of those days a while back where I was all stressed because there wasn't as many patients, I went to visit different doctors, and there is this group of primary cares. They have no podiatrist there, and I'm going to go talk to them about our group via Zoom. No one meets anyone anymore, but Zoom is the way they're doing it, so I'll let you know how that goes tomorrow. Okay, have a great day. If you guys have Amnio, please help me out, who you use, how much you pay, things like that. I'd love to know. We tend to charge $1,500 for ours. I know others charge less, but probably because it costs them less. But if it's just as good, let me know.